Okay, welcome everybody to our social media event, Emerging Treatments for Residual Symptoms of Major Depressive Disorder. We're going to talk also about the residual symptom of insomnia. I'm Dr. Leslie Citrome, Clinical Professor of Psychiatry and Behavioral Sciences at New York Medical College in Valhalla, New York. And I'm joined by two good friends and colleagues, Dr. Joseph Goldberg, who is Clinical Professor of Psychiatry at the Icahn School of Medicine at Mount Sinai in New York, and Dr. Paul Doghramji, who is a family physician and the medical director of health services at Ursinus College in Collegeville, Pennsylvania. Welcome.
Thank you, Les.
So let's get started. Why are we thinking about adjunctive treatments for MDD? Well, primarily because we're not getting to where we need to go, and we're not getting patients all the way into remission. But remission, as defined by symptoms, is not good enough. And you can still have symptoms and do well, or you could not have symptoms and not do well. So we have to think of both symptoms and function at the same time. And my goal, and as I'm sure all the providers listening today, is to get patients all the way better as much as we can and get them functioning as best they can. So, Joe, tell us what's in the pipeline, what's new for adjunctive treatment for MDD?
Well, some of what's new is already out of the pipeline and available. So let's talk about both what's available and what may be coming down the pike. Let's see. Do we have the next slide? I'm only seeing our pictures here. Do we have the slide up?
So, Joe, while you're getting the slides, you were mentioning there's stuff that we already have, like FDA-approved medication. So, aripiprazole, brexpiprazole, cariprazine, quetiapine, olanzapine, fluoxetine combination, esketamine nasal spray added to an antidepressant. We can do all those things, but there are new ones that are emerging.
Yes, indeed. So of the, let's call it older, we have, as you mentioned, some of the dopamine partial agonists, which are interesting because you think about dopamine partial agonism as maybe having particular value for things like motivation and drive and initiative. If intrinsic reward circuitry is diminished in some forms of depression, a dopamine agonist might compensate for that by increasing, say, prefrontal dopamine or dopamine reward circuitry. So that's certainly one aspect. And we have some older medicines that we think of. You've mentioned so lithium, thyroid hormone, bupropion are all things that have been time honored and used as augmentations. But in 2025, not as much data as is the case with the dopamine partial agonist. And then we have the data with esketamine, which has been FDA approved as augmentation therapy with a monoaminergic antidepressant, and more recently has come along as just approved as a monotherapy as well. So if we look to the future,
let me interrupt you, Joe, because I want to ask you a question, and it's been bugging me for a while. So we have FDA approved medication, we have a bunch to select from, and then there's these other medications that are not FDA approved to use adjunctively. What do we do with them, and how do they rate in terms of how you like them?
So I think it varies based on the literature. Some compounds that have preliminary proof of concept, randomized trials, like, for instance, the drug pramipexole, or psychostimulants, or the drug armodafinil, don't have large multi-site, adequately powered safety and efficacy registration grade information that leads to FDA approval. So by comparison, some of those other drugs that I mentioned, I would say, are of interest. Sometimes they're mechanistically appealing. One might think of, for instance, a stimulant in the case of somebody who might have comorbid ADHD, or even just low attentional processing, fatigue, lethargy. One thinks about sort of the target symptoms. Same as we might talk about insomnia as a potential residual symptom in depression, suggesting a type of medicine. But those proof of concept studies don't measure up to quite the same level and magnitude of extensive experience that we have once a drug has gone through the FDA vetting process. So they kind of go side by side. And I think what's especially important also is to be mindful of what's evidence-based from what's not evidence-based. So you could almost think of this in tiers, the sense of something that's gotten the approval and gone through the vetting process with many multi-site trials, or at least 2 very solid multi-site trials, and then proof of concept. But then we have, gee, I've never thought of trying liquid paper before. That'd be off-label, but my friend said it helps him, so might as well go ahead and try that. Would be much more experimental.
Yeah. So what about lithium and thyroid? They're old. They're used as adjuncts in the past. Are they still used today?
They sure are from the past, and they still can be used today. They're not less efficacious now than they were once before. The problems, I think, have to do with, for one, the studies are older, so most of the lithium augmentation trials are added on to tricyclic antidepressants or older SSRIs like fluoxetine or sertraline. So we don't really have any data in the last 25 years that I know of using either T3 or T4 as an augmentation of, let's say, a more modern treatment. And you can make similar arguments for really a lot of the older medicines, thyroid as well. So I think, especially nowadays, if a medicine is sort of in the background based on its history and legacy, one has to kind of go flesh that out and look up the studies. And lo and behold, lithium will give you a 3-fold odds ratio of better response. Lithium has an anti-suicide effect. Lithium has some anti-suicide properties. Lithium may work especially well when there's a family history of either lithium responsivity or bipolar disorder. So one could construct a profile and make an argument for really any given drug. Lithium's a good example of that. And thyroid as well probably hasn't had as much research as even lithium has back in the day. And if you look at the studies, there was one study using T3 augmentation back in the archives from about 30 years ago, and the outcome measure was clear-cut improvement. So the standards by which we quantified outcomes and improvements were maybe not as extensive and rigorous as they are nowadays.
So what's approved by the FDA has been vetted, and we have like 5 choices now. We might have 5 oral choices now and 1 intranasal choice. What's emerging? What can we have in our hands in the next, 5 years? In the short run.
Yeah, so here's that slide I was searching for. So we have a few interesting medications to look at here. You'll be hearing about these as we go along. So the drug iloperidone, which is an atypical antipsychotic that's for quite some time had its indication in schizophrenia, and then a little more recently got its indication in mania, has an active metabolite derivative, milsaperidone, and that compound is now in phase 3 trials looking at adjunctive therapy in major depressive disorder. So it's another example of an atypical antipsychotic that may have mood benefits separate from the antipsychotic properties, and we are awaiting the clinical trial data. Osavampator. So this is an AMPA receptor positive allosteric modulator. Said more simply, when there's interest in molecules that can block the NMDA receptor, we think ketamine is an example. We think probably dextromethorphan at a high enough dose is an example. Part of what we think goes on at the synapse is the blockade of NMDA receptors, a type of ionotropic glutamate receptor, that allows more shuttling of glutamate particles to the next door neighbor, the other ionotropic glutamate receptor called the AMPA receptor. And a positive allosteric modulator is a ligand that binds to a substrate at a location that's different from where the glutamate molecule binds, and facilitates activity of the receptor. So this would be sort of a spin-off, I won't say of ketamine, but of the mechanistic rationale for a drug perhaps like ketamine or perhaps like dextromethorphan as another way to sort of get the glutamate system moving where you want it to move in such a way as to increase neurogenesis and neuronal plasticity. Then we have this interesting class of drugs called TAAR1 agonists, trace amine receptor agonists. And there's a whole class of medicines that has been looked at in modulating amino acids that can play a role in, well, a variety of things: psychosis and schizophrenia, mood symptoms in bipolar disorder, possibly in major depression as well. Some mixed data at the moment. So Lumateron was one of the first of these TAAR1 agonists that came along. There was a positive study that was published in schizophrenia in the New England Journal not too long ago, but then some more mixed data after that. So I'd say the story, or the jury rather, is still out on whether or not particular TAAR1 agonists or TAAR1 agonists as a class are going to prove to have some robust value for mood. Now, everybody and their brother and sister is really interested in psychedelics at this point. You can't go to a meeting nowadays and not within 30 seconds, someone asks about psychedelics. So one example of a psychedelic is psilocin. There is a molecule that goes by the moniker of CYB003, which is a deuterated form of psilocin. It's another way of trying to bind to 5-HT2A receptors as an agonist. Now, this is a little tricky because atypical antipsychotics bind to that receptor as an antagonist and are thought to exert antidepressant properties through 5-HT2A blockade. You'll see that in a moment with lumateperone. Of its various properties, one is 5-HT2A antagonism. Yet, psychedelics, in particular indolamines, and psilocin is an example of that, have an agonistic effect. So you can get a potential psychotomimetic pharmacodynamic effect, but then an antidepressant effect. And I think, to the best of my understanding, our field is not yet quite clear on how that duality can be. Is it sort of a hit and run effect? Is it that the psychedelic, psychotropic or psychotomimetic effect happens, but then downstream you get this antidepressant effect? So I think the answer to explaining 5-HT2A agonism versus antagonism is still an unknown, but remains of great interest. And in the meantime, we have clinical trials ongoing with agents such as CYB003, and there are certainly others as well. These still are all Schedule 1 drugs, which is to say you can't go out and just prescribe them legally. But there are research studies that can be found, say, on clinicaltrials.gov if a patient is contemplating one of these psychedelic molecules. Paul's going to tell us about seltorexant. This is a selective orexin 2 receptor antagonist, and I'll leave that for him. And then last on this list is another one of the atypical antipsychotics, lumateperone, which I'll be talking about a bit more, but it is a multi-action molecule. It happens to be an antipsychotic. It's got some antagonism at the D2 receptor, but in particular seems to have a very robust antagonistic effect at the serotonin 2A receptor that we were just talking about a moment ago. And it does other things too. It's got some binding at T1 receptors that might modulate glutamate. So these are all examples of novel approaches to treating depression.
Well, great. Lumateperone is possibly going to be approved this year. Seltorexant follows that. I'm not sure when. But Paul, take us through what is seltorexant? What's the evidence behind that?
Yeah, sure. Can you put the slide up? I'm not sure if I should do it or if somebody else can.
We have the slide dilemma again.
Let me see if I can do it. Oh, there we go. Somebody did it for me. Great. Thank you. Seltorexant. Now, as you probably all know, folks, there's all these Rexants that have already come out. Daridorexant, Lemborexant, the first one that came out was Suvorexant. And these are orexin receptor antagonists. And as we know, there are orexin 1 and orexin 2 receptor sites. As you can see down there, OX1R, OX2R. And the three that have come out have been prescribed for insomnia, both for sleep onset insomnia as well as sleep maintenance insomnia, and only for insomnia affecting both receptors OX1 and OX2. Now, interestingly, we've always known that patients with depression, major depressive disorder, have a very high degree of insomnia. And there have been clinical studies that have come out showing that if you treat somebody with major depressive disorder who has insomnia with an insomnia medicine, typically the studies that have come out in the past have been with benzodiazepine receptor agonists, their response and remission rates have been pretty good. So now it comes seltorexant, another orexin receptor antagonist, but this one, this orexin receptor antagonist is only for the orexin 2 receptor. So how does that differ, and what does that do differently? Well, it's been studied in major depressive disorder, and if I can show you the next slide. Thank you very much. In patients with depression who have not had an adequate response. So this is the change in the MADRS score over time, as you can see there, over 6 weeks in patients who have not had an adequate response to and already taking an antidepressant. And as you can see, it was placebo, seltorexant 10, 20, and 40 milligrams. and looking at the decrease in the MADRS score. And as I'm sure you know, the lower the MADRS score, the better the patient is doing as far as depression goes. And there does seem to be some benefit in improving the MADRS scores, in improving depression in these patients over a 6-week period of time using this orexin receptor antagonist. So an interesting thing. Now, in this study, I should tell you that these patients, some of them had insomnia and some didn't, and it was not stratified by, or it was not inclusive or exclusive of patients that did or did not have insomnia. Next slide, please. Now, this one shows you the ISI scores, the Insomnia Severity Index. Now, the majority of these patients, or a lot of patients that were in this study, they did have an ISI score that was abnormal. A lot of them did have insomnia, and as time went on, it looked like their ISI scores did also improve. So the baseline score, as you can see on the left-hand side, as well as on the right-hand side, with placebo as well as seltorexant and all the different dosages, did seem to have some improvement in the ISI score. So, this is an interesting concept to me, which is that if you improve, if you have somebody with major depressive disorder who is having a partial response, if you give them something that actually works on their orexin receptors, what are you actually doing? Are you improving sleep, which is improving their depression, or are you doing something else to their pathophysiology of depression to improve their MADRS scores, to improve their depression symptoms? Next slide, please. Now, is there an adverse event profile to this medication, as there would be with any medication, as you can see there? And maybe the first thing that I want you to look at is the second line there, which shows the discontinuation rate due to treatment-emergent adverse events. So placebo, it's around 1.5%. And if you go across the board from 10, 20, and 40 milligrams, the discontinuation rate goes from 3% to 1.6% to 7%. So some patients did discontinue, but no more than 7% with the highest dose, which was 40 milligrams. So some of the side effects were headache, somnolence, as you would expect. Some somnolence would be there, some nausea, diarrhea. Insomnia occurred infrequently in the dosages, but maybe occurred in the 1% with the 40 milligrams. And some treatment-emergent adverse events of special interest, some abnormal dreams. Again, this is something which is working on the orexin receptor. And if you work on the orexin receptor, are you going to cause any of the narcoleptic type symptoms, like sleep paralysis, and maybe there was a little bit of sleep paralysis that was seen, some nightmare, abnormal dreams, and some parasomnias. Actually, no parasomnias were seen in the seltorexant study. So an interesting study of an orexin 2 receptor antagonist that might help in patients with MDD not reaching a good response with the depression medicine that they're taking. I think that's my last slide.
Yeah. So, Paul, that's very interesting. This orexin receptor antagonist added to an antidepressant not only helps depression, but potentially, of course, with sleep. But it still worked in those who didn't have a problem with sleep to begin with. So that's very interesting to see. Joe, take us through Lumateron. That's going to be in our hands pretty soon for adjunctive use in MDD.
Indeed. It's already in our hands for the treatment of schizophrenia and also for the treatment of depression and bipolar 1 or bipolar 2 disorder. And as you mentioned earlier, Les, so there's a review package in front of the FDA right now looking at its potential use as augmentation treatment in major depressive disorder that is added to a monoaminergic antidepressant. So already talked about the mechanism. We think various means by which we could modulate neurotransmission in the glutamate system through D1 receptors, and modulating AMPA and NMDA that way, the 5-HT2A blockade. And it does have some D2 antagonism, but that may bear more on the antipsychotic properties, the antidepressant properties. So let's have a look at the data. If we get the next slide, there have been 2 studies so far. Neither's yet been published in a peer-reviewed journal, but they've been presented as posters. The first of these was presented last year. It's now in front of the FDA. So there's a large study of unipolar major depression patients who hadn't gotten adequately better, responsive to a traditional antidepressant treatment. A proportion of the group was given augmentation with lumateperone. It comes as one dose only, 42 milligrams, or placebo. And as you can see on the left, we were talking about the MADRS scale before, this standardized measure of severity of different types of major depression symptoms. We see separation from placebo beginning at the first week and throughout all 7 weeks of the 6 weeks of the clinical trial. And on the right, we have a secondary outcome measure, something known as the Clinical Global Impression Scale. And that's kind of a different gestalt of 7 points of description of levels of severity of illness from not at all ill to among the most severely ill. And those findings with global impressions of severity mirrored what we saw with depression symptom improvement. The differences were statistically significant. That effect size that you can see down there is sort of a moderate to large effect size, which means that it's clinically meaningful. It's not just not a fluke statistically, but it actually will have a meaningful impact. Then the second study that we'll see on the next slide, quite similar to what we saw in the first study. Once again, significant improvement with adjunctive lumateperone added to an antidepressant as compared to just continuing that antidepressant with a placebo. Separation here seen now after 2 weeks and then throughout the study on the left. Once again, these effect sizes, we should spend even more time talking about effect sizes, but suffice to say, when you see that decimal number of 0.5 or greater, that means it's at least a medium effect size, which is considered to have some substantial bearing. SSRIs, for example, in major depression, tend to have somewhat smaller effect sizes than that, sometimes in the 0.3, 0.4 range. So 0.5 is awfully respectable, and again, mirrored on the right with the Clinical Global Impression score showing an advantage over placebo. And there may be another slide. So adverse effects. So everything has its side effects. No new adverse effects noted in these lumateperone adjunctive depression studies than compared to the earlier studies that are now the basis of its existing FDA approval as monotherapy for bipolar 1 or bipolar 2 depression, or for schizophrenia. That is, somnolence, nausea tend to be the leaders of the side effect profile. Some dizziness and GI complaints as well. Of note, this is a drug that does not seem to confer metabolic dysregulation. So in studies that have been done over the course of time in bipolar disorder, in schizophrenia, and now we have these short-term studies as adjunctive treatment in major depression, we don't really see differences compared to placebo in body mass index, weight, or in some of the bipolar studies. Even the metabolic parameters like lipids and glycemics also seem pretty stable over the course of at least 6 months. So that's good news for everyone who's trying to do no harm metabolically to a patient. And lastly, maybe because this drug is not that potent a binder at the D2 dopamine receptor, we don't see a lot of collateral damage in the dorsal striatum. So extrapyramidal symptoms, Parkinsonism, even hyperprolactinemia really was minimally different from placebo. So another plus for this drug, perhaps as compared to other antipsychotics, is it may be quite sparing of some of the adverse effects that we often think of with antipsychotics. And also no cardiometabolic issues were observed with this drug.
Well, it sounds good. You know, I like to have choices, and I like these choices to be different one from the other. So this certainly is a different antipsychotic to consider, and we look forward to hearing more about it in the coming weeks. So there are some other agents of interest here that you may have heard of. Solriamfetol is a drug that is used for excessive daytime sedation. It's used for narcolepsy, OSA, but it's an NDRI, norepinephrine dopamine reuptake inhibitor. We know that bupropion is an NDRI. That's interesting. So maybe it could help with depression, and there's been some preliminary work in that direction, and we may hear about more of that in the coming months and years. There is an agent that is in our hands today that was approved as essentially monotherapy. It's a combination drug approved as a monotherapy, a single pill, dextromethorphan bupropion combination. It's a very different antidepressant medication that appears to work rather quickly, and it's used actually not as originally intended for most patients. What do I mean by that? Well, in a retrospective study, of a large claims database over 20,000 patients, it was used as a monotherapy, that is the only drug for MDD, in only about 30% of patients. So 70% were getting it as adjunctive therapy. That's interesting because we have no real systematic data, systematically collected data regarding adjunctive use. But this is practice-based evidence, and there must be something to it. And I hope someone will do some research there that will answer the question.
Can I make a quick comment, Les? Just
sure.
On that, as our listeners are thinking about this, so if one were to consider using dextromethorphan bupropion with other drugs, just be wary of the interaction with the 2D6 cytochrome. Maybe you were going to say this, and I'm stealing your thunder on it, but that's okay. So the whole rationale of bupropion is to inhibit the metabolism of dextromethorphan through cytochrome P452D6, and that works out well and good. But if you're going to add this drug onto other things, as you were showing, I might be leery about adding it onto fluoxetine or paroxetine or any other drug that's got additional 2D6 inhibition, because now you're going to make a much more hard to predict pharmacokinetic result with a dextromethorphan.
Yeah, so thanks for reminding me of that. The dextromethorphan is doing the heavy lifting here. It's not the bupropion, and bupropion acts as just to make dextromethorphan more available over time. The product label does say, if you're taking also a CYP2D6 inhibitor, that the dose is reduced to once per day. So it is feasible, and that is how it's being used, it seems. Well, we're nearing the time of our discussion. We have about 3.5 minutes left. Is there any comments about what we've already talked about? Any burning issues that bother you or intrigue you? Well, I have one. And it's the same one that I asked Joe about earlier on. What do we do about these patients who are on all these things that there's no great evidence base, and they're on combinations? Should we remove some of these medications? Should we deprescribe things that are not helpful?
How funnily you asked that question, Les, with a smile on your face. So Les and I are part of an organization called the American Society of Clinical Psychopharmacology, and have just submitted for publication a fairly large manuscript that talks about this notion of when is there an end point, or when is there an identified instance of saying this isn't working, or this may not be a good fit for this clinical constellation of symptoms. And so the term deprescribing has gotten very popular in recent months, but it's really meant to be used in psychiatry no differently than elsewhere in medicine. It's to say that there's either a redundancy or a lack of efficacy, or adverse effects outweigh benefits, or the wrong tool for the wrong job. So I'd say in brief, it is incumbent on all of us who treat patients and prescribe medicines to always be thinking about the fit between the presentation the patient's showing us and whether the intervention I'm providing them has a rationale and an evidence base. FDA trials are helpful for that. But moreover, an adequate trial, if you're using measurement-based care, you're using a PHQ-9 or something to track depression, and you don't see something happening and the patient's not getting at least a partial improvement after an adequate trial, it starts to beg the question, do you retain that treatment? Do you augment that treatment? Or do you sunset that treatment in favor of something else? And while we don't have a simple answer to that question today, I'd like to leave us all with the notion that we should be asking ourselves and our patients those questions in a very collaborative, shared decision-making way. Nothing's worse than seeing someone persistently depressed on the same medicine or medicines for such a long period of time, and no one's thought to stop that and try something else.
Yeah, that's a good point. Our psychotropic medications often make it kind of difficult to ascertain, is it really helpful? Are we, wasting our time here? Paul, what would you do in someone with hypertension, for example, who's on 2 antihypertensives and you're not sure whether that's going to really work well for that person?
There are examples in various aspects of medicine, hypertension, cholesterol, diabetes, etc., where one medicine alone isn't effective enough. And I tell my patients that come in with MDD when I diagnose them with it, that there's about a 50-50 chance, maybe even more than a 50-50 chance, that if this medicine is effective, it's not going to be effective enough, and I'm going to be adding something to what you're doing. I say that all the time to my hypertensive patients, cholesterol patients, diabetic patients, etc. So there's precedence in all these fields. So I think that it's very important, in my opinion, when patients come in and we diagnose them with MDD, to let them know that as the initial treatment period goes on, and we see them very frequently, that they're probably going to need, or there's a very good chance, at least 50-50 chance, they're going to need something else. And what that other medication is, and fortunately, we're getting a lot of augmenting choices for us to use for our patients.
Well, thank you for that. You know, the bottom line is we want our patients to get better. We want to get rid of the residual symptoms and have them function better. That means addressing insomnia, fatigue, concentration, and so on. And we suspect that this will improve quality of life for patients living with MDD. And these novel investigational agents may fit into our treatment paradigm. We'll have to see. I'd like everyone to take a look at the slide that is being shown to you where you can claim credit for participating in this activity. There's also a URL if you don't want to use the QR code. I'll leave that up for a couple of seconds there. A bit more. You got it? Okay. Joe, Paul, thank you so much for this great discussion, and I want to thank you, the audience, for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.